I'm Emily Borman-Shope. I'm the Vice Chair of Education in our department. Sorry to get us started a little bit late this morning. We had some minor technical difficulties that we were working out. I'm going to let our department chair, Dr. Neglia, say a few words of welcome, and then we'll introduce our speaker for today.
Great. So thank you, Emily. Good morning, everyone. I want to give a special welcome to our first-year residents who are attending their first grand rounds today. So welcome to all of you. We're very glad you're here. It's obviously a little different structure than you probably thought you were going to be rolling into when you matched, but we're making it work, and we will keep making it work as long as we need to. We have a great grand rounds for today. Our speaker today is Dr. Gail Brottman. Dr. Brottman is an assistant professor of pediatrics at the University of Minnesota, but most of her time is spent at Hennepin Healthcare, where she is the director of pediatric pulmonary medicine. Dr. Brottman is a graduate of the Rosalind Franklin School of Medicine in Chicago. Back then it was simply called the Chicago School of Medicine. All of us are adding names to our organizations now, it seems. She followed her medical school up with a residency here at the University of Minnesota and then a pulmonary medicine fellowship. Dr. Brottman is an outstanding asthma physician, and we are very excited to hear her grand rounds today. So,
all right,
Gail.
Thank you, Dr. Neglia. I'm going to share my screen. Okay, it says host disabled participant screen sharing.
Emily, if you're saying something, you're muted.
Oh, sorry. I just was saying that I accidentally put Dr. Brottman on hold, which I didn't even know was a feature of Zoom. So always learning.
Okay, so I'm gonna do my PowerPoint. Okay, can you see my slides, Emily?
We're not seeing them yet. Hold on.
Not yet.
Sorry, everybody. We've been very smooth the past couple of weeks, but apparently we're having a little summer. Yes, I joined from my iPad. It has less features.
Okay, so
I will get it started in 1 second. Our Grand Rounds coordinator is just getting it fixed for you. There we go.
Okay, can you see my screen?
Yep, looks great.
Looks great.
Okay, and then, all right, can you hear me?
We sure can.
Fantastic. All right, great. Good morning, everybody. Thank you for joining us today. I'm going to be talking about asthma management in the time of COVID-19, as I was telling Dr. Borman-Shope. When I was planning this grand rounds, I was just going to talk about some new guidelines and new recommendations for asthma management. And then we had our lovely pandemic. And so it seemed very timely to try to add in some current information about the current asthma management recommendations during this pandemic. My disclosures are the following. I do serve as a consultant for a company called Point of Care Decision Support. This is the software company that helped develop and currently own the electronic asthma action plan that is embedded into both Epic at Hennepin and at Fairview, which is a computerized decision support tool to help providers follow guidelines in asthma care. And I'll also be discussing some off-label use of medication, specifically budesonide formoterol combination inhaler, otherwise known as Symbicort. Okay. Emily, can you advance the slides? I am not able to.
It's usually in the sort of lower left-hand.
Okay, I just used my mouse.
Great.
So what I want to do today is discuss recommendations, the new recommendations for asthma treatment in young children and adolescents and adults from the NAEPP, otherwise known as the National Asthma Education Prevention Program, the Global Initiative for Asthma, otherwise known as GINA, and the Agency for Healthcare Research and Quality, otherwise known as AHRQ. And then I'm going to review the current data about whether having asthma is a risk for severe complications from COVID-19 and implications for asthma treatment during the pandemic. So just a little bit about the burden of asthma in Minnesota. And I show this slide mostly because when people do sign outs, typically we hear, oh, well, it's just asthma. About 408,000 Minnesotans currently have asthma. That's 1 in 14 children and 1 in 13 adults. Back in 2016, there were 18,000 emergency department visits and about 2,000 hospitalizations for asthma across the state. Asthma emergency department visit rates for children living in the Twin Cities metro area are twice as high as greater Minnesota, and asthma hospitalization rates for children in the Twin Cities are 2/3 as high, 67% higher than children living in greater Minnesota. There are huge disparities in both asthma prevalence and asthma care, which I'm not going to go into today, but asthma death rates are 4 times higher among African Americans and twice as high among Asian Pacific Islanders than among Caucasian. So our goals of asthma care, and you'll notice that this is from the NIH publication in 1997, they have not changed. Basically that people with asthma should not miss school or work. They should be able to sleep, have healthy sleep, maintain normal activity levels, not go to the ER or be hospitalized, and have normal or near normal lung function. So in terms of establishing the diagnosis of asthma, there needs to be 3 factors. One is that you have to determine that there is an airflow obstruction, which is at least partially reversible, that the person has episodic symptoms of airway hyperresponsiveness, and this is actually just the ability to wheeze. And underlying all of this is airway inflammation, which is actually the primary driver of both the airway hyperresponsiveness and the airflow obstruction. So for those residents who have worked with me in the past, and those staff who have known me for some time, I have my very personal pet peeve is the term reactive airways disease. And so I just want to put this up there. I do have this reference available. I think it's on a Google Drive called Reactive Airways Disease, a lazy term of uncertain meaning that should be abandoned. Notice this is from 2001. I'm not going to go over, I just put this in here that you know that asthma is an inflammatory airway disease. So hopefully you will not use the term reactive airways disease. So I want to jump into just one small part of diagnosing asthma, because this is really the most challenging diagnosis in children aged 0 to 5 years of age. As we know, bronchiolitis is a common problem with young children, but and all that wheezes is not asthma. The challenge is that there's really no test to diagnose asthma in young children. We do have pulmonary function tests available. They're not very practical for in clinic or an outpatient venue. And so it's really important to understand that, that there are different asthma phenotypes in young children. And this was actually well described back in 1995 by Fernando Martinez in a group in Tucson, where they actually prospectively followed over 1,000 children from birth, and actually they're still following them now. This is now 20 years later. And what they did was they identified 3 different groups of children. There's early wheezers, which have recurrent wheezing episodes beginning in infancy, but these children tend to stop wheezing by the age of 3 years. There's a late onset wheezer. These are children who do not wheeze when they're infants. They have their first wheezing episodes generally after 4 to 6 years of age. And then there's those persistent wheezers who start wheezing when they're young and then have ongoing wheezing into childhood and adolescence. And really the asthma predictive index was developed to differentiate these early wheezers from the persistent wheezers because those persistent wheezers are going to be the ones who are at the greatest risk for asthma later in life. And the API is the basis for both the NHLBI and the GINA recommendations for when to start inhaled steroids in young children. And again, this is always something that, that we struggle with. So the API is actually quite a functional tool that you have to have. An API score requires recurrent episodes of wheezing during the first 3 years of life, and you have to have one of 2 major criteria, being that you have a physician or a healthcare provider diagnosed eczema or parental asthma. 2 of 3 minor criteria with a diagnosis of allergic rhinitis, wheezing without colds or between colds, and a peripheral eosinophilia. And the definition of a stringent API is that you have greater than or equal to 3 wheezing episodes per year, and one of the 2 major or 2 of the minor criteria. And what's considered a loose API is if you have less than 3 episodes of wheezing per year, and one of the major or 2 of the minor criteria. And basically, if you have a positive stringent API by the age of 3 years, that you have a 77% chance of having active asthma when you're age 6 to 13. And this is important because the sooner we start treatment, the better the outcomes, short-term and long-term. This is something that was actually developed in Cincinnati. One of our former residents, Teresa Gilbert, actually participated in this study. And actually I like this because it was developed using factors from the API, but it also includes race. And you can actually find this online. You can just Google pediatric asthma risk score, and it has this little in color thing, and you can see that if you get a score between 9 and 14 and you're high risk, that children with these scores have a 2 and 5 or a 4 and 5 risk of developing asthma by age 7 years. And so this is actually a quite convenient tool to use with when you're seeing your young patients with wheezing. So in terms of really making the diagnosis of asthma in 0 to 4-year-olds, the recommendations are that if they have a positive asthma predictive index or PAR score, that you do a trial of treatment for at least 2 to 3 months with a daily low-dose inhaled steroid and as needed beta agonist, meaning albuterol or levoalbuterol. You should evaluate your response by symptom control and the frequency of wheezing episodes and exacerbations. And when I say wheezing episodes, we're not just talking about ER visits. I think the important thing is to really get a history of, you know, how often are people wheezing in between colds? Do they wheeze? How often are parents giving albuterol for the wheezing, even if they're not having what would be considered to be an asthma attack or an exacerbation? And that marked clinical improvement during treatment and deterioration when treatment is stopped support an asthma diagnosis, and that you actually may need to repeat the therapeutic trial. So I get a lot of, you know, I gave this kid five days of prednisone and they didn't get any better, so what does that mean? And we tried the budesonide for 2 weeks and it didn't really help. And I think that, again, when you're talking about ongoing airway inflammation, that this might not be an adequate trial. So that you should keep this in mind when you're making the diagnosis of asthma. So just to get into the changes in the GINA, NAPP, and AHRQ asthma treatment recommendations. This is what the stepwise approach looks like from the NAPP. And I didn't put the whole page on here, but this is for 0 to 4-year-olds. There's a 5 to 11-year-old and a 12-year-old, greater than or equal to 12-year-old. And there's step 1, 2, 3, 4, 5, and 6 based on the severity of the symptoms, and the recommendations for treatment are here with the idea that the more severe your asthma symptoms, meaning the more frequent your symptoms, the more frequent exacerbations, the more airway inflammation you have. The more airway inflammation you have determines the dose of inhaled steroids, right? Because again, you're trying to decrease the airway inflammation, which is driving your wheezing symptoms. And so this is what the NAPP stepwise approach looks like. And for children less than 5 years old with recurrent wheezing and a positive API, currently on no controllers, right? So these are your virally induced wheezing kids. These are the babies or the toddlers in daycare who come in, and every time they get a cold, once a month, because they're in daycare and they're wheezing, but in between they really have no wheezing and they're very healthy, that the recommendation is that you should use intermittent inhaled steroids during an upper respiratory tract infection. And this has been shown to decrease asthma exacerbations. Okay, this is the recommendation. We don't use what I call wussy doses of, pardon the poor language, of budesonide. What they're recommending is high dose inhaled steroids. Budesonide 1 milligram twice daily for 7 days at the first sign of an upper respiratory tract infection. For children 4 years and older and adults with mild to moderate persistent asthma on a daily inhaled corticosteroid, this is for people who say, well, just double up that flow vent when you have a cold. There was actually a really nice New England Journal article published in 2018 that showed that doubling, quadrupling, or even quintupling the regular daily dose of inhaled steroids really doesn't prevent progression in an asthma exacerbation. And remember, if you have patients on combination inhalers, that you can't quadruple the dose because of the long-acting beta agonist component. So this is what the GINA guideline recommendation looks like, and this comes from a really nice slide set that's available, publicly available. What they do is have kind of more this circular review, response, assess, adjust treatment. You're looking for symptoms, risk factors, asthma medication. Their steps are down here. The steps are very similar. And previously in step 1, that they recommend no controller, and that's actually what the recommendation is currently from the NAEPP, with as needed albuterol. So this is step 1, is typically what we identify as exercise-induced asthma. The recommendations for adults and adolescents 12 years and older is now, and this is new, this is the new news, is that in step 1, that they are recommending as needed low dose inhaled steroid and formoterol combination. This is Symbicort. The Symbicort comes in 2 strengths, 80 micrograms and 160 micrograms with the formoterol. So the as needed would be to pre-medicate for exercise. Basically, you'd pre-medicate with this combination inhaler. And then they're also recommending an as needed low dose ICS formoterol combination. Now, what I will tell you very briefly, that there was a huge discussion on several chat rooms, Peds Lung, and specifically, which I've been a member for quite some time. These are pediatric pulmonologists and respirologists from all over the world, saying that, you know, this was a drug company sponsored trial, that AstraZeneca, that this isn't fair, it was biased. To be fair, there is Dulera, which is mometasone formoterol combination. And the question was as well, instead of using Symbicort or budesonide formoterol, could you use mometasone and formoterol? Again, the reason you're using the formoterol is because it's a long-acting beta agonist with a very quick onset. So the onset is just as quick as albuterol, but it lasts for 12 hours. And, you know, I think that that's why the medication name Symbicort is not on here, but that was what is in the publications. When we're looking at HRQ recommendations, and what they did was ask some key questions. This is the way they do things. They asked about, they wanted to assess the efficacy of intermittent inhaled corticosteroids in different populations of patients with asthma, and they took it by different age ranges. So again, in patients 0 to 4 years of age with recurrent wheezing, that this is, again, what you saw in the NAEPP, and Gina as well, by the way, that the intermittent inhaled corticosteroids with the short-acting beta agonist as needed versus just treating those wheezing episodes with albuterol alone at the onset of a URI. So again, what you want to do is start those inhaled steroids. These are kids with recurrent wheezing and positive API, and use that. And basically, this improves the outcome. And again, in patients 12 years and older, they are also recommending using inhaled steroids and long-acting beta agonists together as both a controller and a quick relief therapy to reduce asthma exacerbations. So I want to jump right into COVID-19 and asthma. And I was telling Dr. Borman-Shope that I really wasn't hoping for a lot of information, but I was actually pretty impressed at there is some information, and I hopefully you'll find this interesting and very practical for how to treat asthma during this pandemic. So we saw this slide actually when our infectious disease division did a lovely review. I think this was back in March. And just about the SARS-CoV-2 binding sites, that it's these spike proteins on the virus that engage with this angiotensin converting enzyme 2 as the entry receptor. And then basically what happens is that this cellular serine proteinase, TMP RSS2, binds to the S protein, and this is what helps facilitate cell entry. And the important thing to remember is that the higher the ACE2 expression, it increases your in vitro susceptibility to COVID-19, and that also seems to translate into the severity of clinical disease, and I'll get into that in just a minute. And what it turns out is that children have lower levels of this ACE2 receptor, and that may be why we're seeing less severe disease. So according to the World Health Organization and the CDC, they have historically listed asthma as a risk factor for severe COVID-19 illness. But in looking at the data, and this is initial data that was published in the Lancet from China, so we got a lot of information from Wuhan, China, and then subsequent from Europe, and now obviously we have more from the US that's being published daily. But if you look at the asthma, if you look at the patients with asthma and COVID-19, the numbers are actually quite small. However, the CDC in March actually still noted that it was quite small in children, but they did see that in adults aged 18 to 49 years old hospitalized with COVID-19, about 27% had a history of asthma. Now, I think the question here is whether or not having a history of asthma contributed to the hospitalization or the severity of disease. We know that that the COVID-19 has been disproportionately impacting people of color who have a higher incidence of asthma and diabetes. So I'm not sure. I felt compelled to put that in there just for informational purposes, but I think we need to really, we're going to really need to take a look at that over time. So why would patients with asthma be less impacted by COVID-19? And I want to get back to this ACE2 receptor. And so the hypothesis, one hypothesis, and this came out of a study that was done, actually it was a multi-center study, but it was published from Madison, that the hypothesis was that whether or not people with asthma and allergies have lower ACE2 gene expression in their airway cells, resulting in a decreased susceptibility to COVID-19 infection. And so what they did was they looked at whether asthma and respiratory allergy were associated with decreased expression in 3 different cohorts of children and adults from the Eureka study, which is the urban environment and childhood asthma study. And what they did was they looked at total RNA extracted from nasal or lower airway epithelial brush samples with RNA sequencing. And what they found, and I apologize for the size of these, hopefully you can see them, is that if you look at this graph A, is that this is ACE2 expression, and this is your asthma and atopy grouping. And if in these boxes, these people had no asthma and low IgE sensitivity. On this end, they had positive asthma and high IgE sensitivity. And what you can see is that there were lower ACE2 levels in with both atopy and atopic asthma. And then in graph B, they looked at degree of sensitization within asthma. And again, you can see that children with both asthma and the highest IgE sensitization had the lowest level of ACE2 levels. Interestingly, patients with non-atopic asthma really did not have any reduced ACE2 expression. What they did then, and these were small studies, looked at adults with allergic rhinitis, and these were people who were allergic to cats, and they looked in panel A for ACE expression in nasal brushings, 8 hours, so this is baseline. This is 8 hours after being exposed to the kitty, and this was 2 days after being exposed to the kitties. And so this was noted to be slightly lower. What I thought was fascinating was that in panel B, they did bronchial epithelial brush samples 48 hours after a segmental bronchial allergen challenge. So what they do with the bronchial allergen challenge is basically figure out what you're allergic to, during a bronchoscopy, squirt some of that allergen down into your airways, and then do a brush sampling and an analysis. And yes, in fact, people volunteer to do these studies. And you can see that with the post-bronchial allergen challenge, there was a really significant decrease in the ACE2 expression. So clearly, asthma seems to be associated with some sort of decrease in this ACE2 receptor expression. And that was really looked into again in another study that was published by the Severe Asthma Research Program. For any of you interested in asthma or severe asthma, this is really an amazing study. It was actually now 8 years old and basically was developed to really improve the understanding of severe asthma and develop better treatments through multiple factors. And they actually start recruiting patients 6 years and older. The SARP-3 protocol is an ongoing study, 6 visits, 3-year longitudinal cohort study, where 60% have severe asthma per the ATS, or American Thoracic Society, ERS, European Respiratory Society guidelines. And what they did was they looked at sputum RNA on 330 asthma patients and compared to 79 healthy controls. Again, we're looking at those ACE2 and TMPRSS2 gene expression. And what they did was also looked at ICAM1 receptor expression because this is a receptor for human rhinovirus. And we know that human rhinovirus is a very common cause of asthma exacerbations in people with asthma. So what they found was basically that there was no difference between patients with asthma and healthy controls in these 2 gene expression, that as you would expect, that they increased with age, that they're significantly higher in males than females, which I thought was interesting, although those ACE2 receptors seem to be somewhat associated with female sex hormones, estrogen levels, and the such, that they're higher in African Americans than Caucasians. And again, this may be something related to the health disparities that we're seeing in terms of the COVID-19, and higher in patients with diabetes, which we know diabetes and obesity are risk factors for more severe COVID-19 disease. And so when they, so those were the findings. And then what they wanted to do is say, okay, well, what happens with these people who have asthma who are on inhaled steroids? Because mostly all of these patients would be on some sort of anti-inflammatory therapy. And so what they did in this panel A was actually look at, this is the amount of inhaled steroids. So this is none. This is a low and medium dose of inhaled steroid. And these are high dose inhaled steroids. And this is the ACE2 expression. And you can see that patients who are on high dose inhaled steroids actually had lower expression of ACE2, TMP, RSS2, compared to the ICAM1, which is interesting because even though the patients are taking inhaled steroids, really this doesn't change their susceptibility necessarily to the rhinovirus. And what they did was they looked at the effect of a triamcinolone injection on sputum gene expression. And I thought this was interesting because really there was no difference. And, you know, when I looked at the explanation of, well, in the discussion, so why do you think that there was no difference in the triamcinolone injection, really mimicking a systemic steroid dose? And, you know, there was some discussion about, well, maybe it was the timing and different things. But again, I think there's really a lot to learn about how these ACE2 receptors respond to treatment and sort of how it's involved with airway epithelial cells. So there was a small study done in Belgium looking at ACE2 receptors in lung tissue. And basically what they did was they compared the ACE2 mRNA in lung tissue from controls. So these were obviously not healthy if there was lung tissue, to patients with asthma and asthma COPD overlap syndrome and COPD. And they didn't find any difference. And then they looked at comparison of ACE2 gene expression with controls, with no obstructive airways disease and no inhaled steroids, obstructive airway disease and no inhaled steroids, and obstructive airways disease again using inhaled steroids. And they didn't find any difference. And you know, the theory here again, sort of why are we finding such different results in these ACE2 receptor, is that they felt that maybe it was due to the difference between sputum versus lung tissue. So now we're looking at, well, okay, so it looks like people with asthma have less problems or maybe are hospitalized less or impacted less from COVID-19. But when we're looking at those ACE2 receptors, there seems to be some response to the coronavirus. So, and I just threw up a couple of these, there's more, but that there's some in vitro models that suggest that inhaled steroids alone or in combination with bronchodilator can decrease coronavirus replication and cytokine production. And really the question, and I was asking the question, and fortunately somebody did this for me since this was obviously a big thing. I said, so what is the deal with inhaled steroids and COVID-19? You know, because we worry that, you know, could inhaled steroids actually make the coronavirus infections worse by decreasing the immune system response, and everybody's worried about using inhaled steroids during the pandemic. And so these people from Europe actually did a systematic review to evaluate whether premorbid use of or continued administration of inhaled corticosteroids is a risk factor for adverse outcomes. And they actually went back and looked at SARS or MERS, reviewed 771 publication, 59 for full text review, and basically found that there was really no publications that had any data to answer this question. But clearly there is interest, and what I think will be interesting moving forward, I did find on clinicaltrials.gov 2 studies, one in Paris and one in Stanford, that are actually going to look at using a trial of combination budesonide formoterol or Symbicort, and they have different inhalers in Europe than we do here. High dose Symbicort, 200 micrograms versus usual care. And then the Stanford study is actually going to use, again, high dose budesonide, 1.0 milligram plus formoterol for 7 days compared to placebo for acute respiratory failure. And this was for pneumonia, but they specifically included COVID in this study. So we will wait to see what's happening. Clearly, they are recruiting patients now. So the next question, big question is, what about systemic steroids for asthma exacerbations? So previously, and I actually went back to the World Health Organization website, does or did not recommend the use of systemic corticosteroid treatment in COVID-19 unless if indicated for other reasons such as acute asthma or COPD, but I couldn't find that recommendation, so maybe they're changing it. And then, as many of us have seen, have been widely published in the news, is that there was a recovery study. This is being done through Oxford University, which is a national trial to identify treatments that may be beneficial for people hospitalized with COVID-19. And one of the treatments they were evaluating was dexamethasone. Actually, we were also doing this at Hennepin as a trial. And so what they found in the recovery trial was that with severely ill patients, dexamethasone 6 milligrams once a day for 10 days actually decreased deaths, so mortality, by 1/3 in ventilated patients, by 1/5 in patients receiving oxygen. I think that it's really important to note that there was no benefit among those patients who did not have respiratory support. So again, I think that the jury is still out. Again, we need to be really careful when changing our practice, that these studies are being evaluated by editors and really clearly looking at data and where the data comes from to be sure that we're not doing our patients any harm. So my last slide here, and then I'm gonna open it up to questions. These are my takeaway messages. And I told Dr. Brottman-Shope, I know I have a lot of references here. I'd be happy to share my slides. I just ask that if you are going to further share my slides, that you don't change them, or that you ask permission if you're gonna use these or change them in any way. That really, from what we're seeing now, that obstructive airways diseases may not be a significant risk factor for more severe COVID-19 related disease. Although I think we need to really keep an eye on these young people, and I say that clearly as not a young person, that this 18 to 49-year-old age is going to be something to look at. Again, people are doing better job at collecting comorbid condition information, so I think that's going to be helpful. That your patients with asthma who are on inhaled steroids and combination inhalers, do not step down their medication. Do not stop their medication. That it's important for them to have good asthma control, and it actually may be helpful. A little caveat, there was no information on whether starting people on inhaled steroids or combination who don't have asthma, that's not a thing in terms of preventing severe COVID-19 disease. So don't go start prescribing combination inhalers for people who don't have asthma. Again, the concern about prescribing inhaled, a short course of systemic steroids for asthma exacerbation, that is definitely something we should continue to do. This actually just came into my in-basket yesterday. Literally, I just added this to my slides. That there's a really nice summary article about managing asthma during coronavirus that was published in the Journal of Pediatrics. There's a nice statement from the Canadian Pediatric Society on pediatric asthma and COVID-19. And we clearly will look forward to having more information as we continue to collect data throughout this pandemic. So with that, I'm going to say thank you very much and entertain questions.
Well, somehow the questions blinked off, but I saw them before they left. We had a question about omalizumab and if there's any data on that medication and COVID outcomes. And the person was asking was particularly wondering about IgE levels and ACE2 expression. Had noticed that sort of pattern in some of the data you were presenting.
Right. So I did not find anything specifically looking at that studied ACE2 levels in patients with omalizumab. I will tell you that the Quad AI, the American Academy of Asthma, Allergy, and Immunology does not recommend stopping treatment with the biologics. So there's omalizumab, dupilumab, a lot of the biologics actually decrease either the cytokines or all the things involved with atopy. And I'm sure that we'll be seeing some studies coming out. I did not find anything specifically addressing that.
Great, thanks. And then there was a question about the choice of dose for dexamethasone being 6 milligrams for adult patients, which seemed to be relatively on the low end. Did you see any data about the choice of dexamethasone dose?
That's a great question. I will tell you that I went on the website, that recovery website, where they actually published their whole protocol. I did not see, I didn't look at the whole proposal. I don't know why they picked that. I think that they're using a different dose at Hennepin, and I know that Hennepin is part of a multi-center study where they're using it for 7 days, but I'm not sure why, what the rationale was for choosing that dose. I really have no idea.
Yeah, I thought that's the dose I would use for a baby with
Right. Well, and I think the idea was to use a low dose. I mean, dexamethasone is much more potent than, obviously hydrocortisone, prednisolone. So, and again, I'm not sure why they chose that dose.
Next question is about return to activities. What is your advice for children with asthma or other airway conditions and their families when it comes to returning to school in the fall? Do you recommend returning in person, seeking out remote options, or do we need more data?
Yeah. That's the question. Well, so I think here's what I'm telling my patients, and also about daycare, right? I get a lot of questions about daycare. So I'm really taking a very practical approach here. What I'm telling parents about daycare, and I would tell them about school, is that if it's a choice between sending your child to daycare and school so you can work and make money and not have food insecurity and not lose your housing, that I think that you should just use your best judgment and, send your child to daycare or school. I think for me, a key piece is who else is in the household, right? I mean, we know that children can be asymptomatic. There's a lot of up and back about whether children are carriers or not, or how much of a carrier are children, but we do know a lot of people can be asymptomatic. And so, quite frankly, what I worry about is children going to school, not being super great at social distancing, although I believe that schools are going to require social distancing and masks, and there's a lot of teachers that are also going to be at risk. But who's at home when the kids come home? Is it the grandparent? Is it somebody who's immune suppressed or high risk? And I think that all of those things need to be taken into account. Again, I think that the really important thing is that, especially with providers in the United States, people have been really, really scared about inhaled steroids and prescribing inhaled steroids and saying, oh, just take it for a month and then stop it. I feel that it's really, really important for providers to really be sure that their patients have asthma. If they have asthma, use tools like the asthma control test or some other validated, there's a Tract tool for young children to look at their asthma control. And if their asthma is not well controlled, step up their inhaled steroids or use combination medications and have them stay on it for the school year, right? I mean, typically I try to stop or step down in the summer. I did nothing like that this year. I said, you just stay on your medicine, even if you have no symptoms, and just because we don't know what's going to happen. So that's my answer for school and daycare.
Excellent. We had a question to help all of our new interns who are going to round with you in the next month. What should they say instead of reactive airway disease? Would virally induced asthma be or virally induced wheezing be an acceptable term?
Well, so thank you. That's a fair question. So I think that the important thing here is to really understand that, bronchiolitis is a clinical disease that is caused by respiratory viral infections. And so if you think it's and it's treated differently, right? We don't use bronchodilators and we don't use systemic steroids. And those are per guidelines. You can find the American Academy of Pediatrics if you look up bronchiolitis guidelines. So if it's the first or second episode of wheezing and it's bronchiolitis, then I think you should call it bronchiolitis. I think that if it's the third episode of wheezing and, you start saying, well, what are the risk factors? If it's the third episode of wheezing and basically they have a negative asthma predictive index, you know, you can say, well, this was a virally induced wheezing episode, and you know, this child might be an early wheezer. I think that one of the challenges is we don't really have a term for our early wheezer babies, right? We can we call it infant asthma, infant wheezing with a negative API that's going to go away. You know, I think we need some better words. We need a different diagnosis code. I think our ICD-11 maybe might come up with a better term. But I mean, honestly, I think that to really start looking at risk factors and bringing that into, is this bronchiolitis, which is self-limited, and we just got to treat it conservatively, versus, you know, this child has eczema, mom has asthma, and the sister has asthma, and mom smoked during pregnancy, and this is the third episode of wheezing. Maybe we should be really calling it, you know, even trying a trial of inhaled steroids to say, yes, this is recurrent wheezing with risk factors for asthma. You know, again, that's not a diagnosis code. You can put wheezing unspecified, but I think I would just encourage both the new and the maybe older residents and staff to really try to focus on how can we characterize this more clearly in terms of risk factors.
That's great, thanks. The final question, someone asked about extrapolating those new recommendations for long-acting beta agonist steroid for rescue to younger patients. So right now it's 12 and up, but would that be appropriate for a 9 or a 10 or an 8-year-old?
Right. Great question. So they have started looking at that. They're, you know, this 5 to 11-year-old. Right now, there is not any good data to support that. What I will tell you for me and my practice is that if you, when I have a 10-year-old or an 11-year-old who's looking very athletic and that they're sort of moving towards being an elite athlete, you know, they're doing hockey and basketball and football and things like that. Especially if they're really challenged about taking a daily medication, you know, like, oh, I can't remember because I don't feel sick. I've actually started using those combination inhalers in those kids, especially, you know, if they just can't remember to take their medicine every day. And of course, the population that I deal with, that's a big issue. So I've actually started using that with kind of the 10, 11, 12-year-olds. I still really feel that if somebody has asthma that's not well controlled, that they take a daily asthma controller. And just so you know, if you look at the guidelines, even for 0 to 4-year-old, if you're at step 5 or 6, for sure step 5, they recommend combination inhalers as a daily controller for very young children with poorly controlled asthma. What I would say is at that point, I think that they should be referred to a specialist. You know, those are really the patients as pediatric pulmonologists that we want to see.
All right, wonderful. I think that is probably all we have time for today. Thank you so much for a really great talk with some cutting edge stuff about COVID that I think is going to leave us all thinking. We are not having grand rounds next week, so everyone can enjoy a little summer holiday, and then we'll be reconvening on July 8th. So have a great day, everyone.
Thank you.